Hey there, Internet. Welcome to another installment of Northeast King County Medic 1's Coffee Break videos. Today we're going to be talking about BLS airway management. A couple items that we're going to cover today are think ventilate, not bag, patient position, airway adjuncts, suction, two-person operation, and some ALS stuff as well to include the PEEP valve, end-tidal CO2, and operation of the LifePak 15. Thanks. So one of the first things that I want to talk about is the idea of ventilation versus bagging. Too often I think we have it in our head that we're just going to bag the patient, and that's a one-person job, and you find that we're smashing the bag on the face and delivering breaths that are too forceful and they're overall ineffective. So things that we're looking for to ensure that we're actually ventilating are going to be adequate chest rise and just overall patient improvement, right? So, starting right off with a two-person technique, I'm going to hand the bag off to you. You'll be responsible for ventilations. Keeping in mind you'll use one hand and deliver just enough to give chest rise. I'm going to be using my thumbs to hold the mask on the face and my fingers to pull the jaw up into the mask. So go ahead and breathe. And see, just like that, we've got good chest rise. Okay, good. So, as our patients continue to be difficult, we can do a couple things to troubleshoot that. The next thing we can consider is improving patient position, rather. We can pile a bunch of stuff underneath their shoulders, raising their body up like so, or sometimes it can be just as simple as placing some padding underneath the back of their head, which will raise their head up and get their airway in a better position. So just by doing that, we've made our world just a little bit easier. So again, two-person technique, go ahead and breathe. And we have great chest rise. So we've improved the patient's position, but we may be still having some trouble with getting breaths in. So another thing that we can use, which I kind of think is an underutilized tool, is our oral airway. Little tips and tricks: corner of the mouth to angle of the jaw. That looks like it's going to be appropriately sized. We can start by going in upside down, twist as we put it in, and it should rest just at the opening to the lips. Getting that tongue out of the way. Again, two-person technique, thumbs using some counter pressure and pulling up into the mask. Go ahead and breathe. Good. Again. Awesome. And so another tool that we'd like to talk about today is the suction device. A couple things worth mentioning about suction, and much of it you'll already know, is we're going to enter in the corner of the mouth without suction, without applying any coverage to the little carburetor thingy. We'll go in until we get to the depth that we want to go, cover the carburetor, suction, suction, suction. The rule of thumb is 10 to 15 seconds, but this is what we need to understand about suctioning an airway. If we have a bunch of excess secretions, blood, emesis, or whatever else is in the mouth, and we go and try and bag over top of that, regardless of how long it takes to suction it out, all we run the risk of doing is shoving all of that back into the patient's lungs, and that's going to have tremendous long-term complications for them. So we want to make sure to avoid that. Suction as long as it takes to get their airway clear. Let's dive a little bit more into two-person bagging. Yeah, I like it. All right, so kind of the old way of doing things, or at least the old thought, was that one person could handle this job adequately, and what we ended up with was something like this, right? So we have bagging that's too forceful, we have a suboptimal position, and what you can see here is that by pushing down on the patient's face, I'm drawing their chin to their chest, which causes the tongue, the upper oral pharynx to all get kind of compressed and shoved in front of the trachea. And then if the trachea is occluded while we're trying to put breaths in, where's all that air go? It goes right into their tummy, and then that comes back up onto our nice white shirts, and we don't like that, right? All right, perfect. So what can we do? We can improve the position. So with two people, you can see I'm able to get the chin and the jaw out of the way, getting the tongue out of the way of the back of the throat, and improving the overall position. Go ahead and bag. And we have good chest rise there. Now we're going to talk a little bit about ventilation rate and then quality of ventilation. So what we're looking for is one breath every 6 to 8 seconds, which comes out to about 10 to 12 breaths a minute. So go ahead. 3, 4, 5, 6. There you go. And you'll notice that my trusty partner Skip here is using one hand to deliver those ventilations. And even Skip is a little overeager in his bagging there. What we want to shoot for is just enough to elicit chest rise, which we're finding is far less than we once thought. So you can see with just a very delicate squeeze of the bag, we get good chest rise even from our sim man here. Hey guys, so this is the PEEP valve. You may hear us ask for this. We really just wanted you to see it and see it put into play. It goes on super easy. What you'll see here is you've got this little directional valve that just pulls right out. This goes in its place, and you can dial it up and down like this. Just ask your medic what they would like it set at, and it'll be kind of on you to just keep an eye on it, make sure it doesn't adjust. What it ends up doing is provides a little bit of back pressure on the exhalation, so that'll help keep those lower airways kind of splinted open with that back pressure. Next thing we'll talk about is something you guys have all seen before. It's our end-tidal CO2 monitor. And so what we would like to start doing more and more is putting this into play while we're doing those bag valve mask ventilations, right? So goes in just like that. Again, you guys have all seen this before, so Skip, why don't you go ahead and bring this on over to the patient's face. Good. And what we can use this for is we can watch on the screen of the life pack. Go ahead and breathe. Once every 6 to 8 seconds, 10 to 12 breaths per minute. And so we can use this along with good signs with chest rise, skin signs, overall improvement in the patient condition, but we can also use the monitor to help support some of that information as well. Things we're going to be looking for are those nice deep peaks and valleys on the end-tidal CO2, and that lets us know that we're getting good breaths in and there's at least some air coming out. And then also the SpO2 waveform, when it's got that really consistent kind of peaks and valleys shape to it, that means we're getting a good signal, and we can probably more likely trust that number. Excellent job, sir. Thank you everybody for joining us today. Hopefully you found some of the stuff in this video helpful. The big things that we want you to take away from this is that we're getting away from that terminology of bagging. We really want to pay attention to ventilating the patient. This is no longer really a one-person job. We really expect that there's 2 people managing this airway, and we're looking for good stuff there. We've given you some tips and tricks all from position, additional devices, along with some of the ALS interventions that we can use to help better manage these patients. So if you have any further questions, if you want to get some hands-on stuff, hit your medics up. We're happy to help. Thanks.